about emotion and other components that are essential to our ability to phonate, and that includes speaking as well as singing in a meaningful and engaging fashion. Total body effort is obvious when you look at a singer. That's Springsteen for those of you in the room who have gray hair. He's a rock singer. But it is not just appearance and it's not just pop singers. It is all of us. So we as physicians and speech-language pathologists and singing voice and acting voice specialists and singing teachers need to understand that when we diagnose and treat a voice, whether it be for a medical condition or in a singing studio, we need to train more than the larynx and more than the passages above the larynx, but the entire body. And that's not just imagery, that's real. We will start by talking about the anatomy of the larynx. It seems to be the most sensitive and personal part. Actually, it isn't even necessary for phonation. Our laryngectomy patients speak perfectly understandably with no larynx at all. It is, however, necessary for normal and superior phonation. As a physician or speech-language pathologist or other healthcare provider, when we see somebody, we in our minds go through a process of trying to break down what's going on so we understand where the problem is. I'm still an active singing teacher. We do the same thing in the studio. We don't always use the same vocabulary, but we are essentially doing a diagnosis, analyzing subsystems, figuring out what needs to be fixed, and how to bring the systems back into balance. It is helpful for the studio teacher to understand the anatomy, just as a violinist can tell the difference between the neck and the bridge. An intelligent singer knows the parts of his or her instruments, but I will tell you that while this is very useful information because it helps us think incisively and understand what we mean by imagery, even those of us who have been doing this for a long time don't use these terms in the studio. They just help us understand what we mean by the bel canto terms that our teachers taught us in the studio. But it's useful information for all of us. The larynx can be subdivided into a skeleton, mucosa, intrinsic and extrinsic muscles, any of which may be responsible for a voice problem. The skeleton consists of a thyroid and cricoid cartilages, two arytenoid cartilage, and some other structures that are less important. If you can remember thyroid, cricoid, and arytenoid, you will know the names of pretty much everything in the larynx. There will be a multiple choice test at the end of the laryngeal skeleton, the thyroid cartilage, which is C-shaped, the cricoid, which is circumferential, the only complete circumferential structure in the airway, the hyoid, or tongue bone, and the paired arytenoid cartilages exist in the neck in front of the spinal column, which is bone, with a little bit of intervening soft tissue. When we're born, these structures are up around the second or third cervical vertebrae, and as we age, the larynx drops in the neck to around the sixth or seventh cervical vertebra. That lengthening of the vocal tract is part of what we perceive as vocal aging. When we are born, these cartilages are cartilage. However, as we age, starting in our teens, they begin to ossify. They become bone. So if you are young in your 20s and you're struck in the front of the neck by a steering wheel or by a soprano on stage singing the final note, don't laugh. I've had a couple of patients who have essentially had karate chops with circumferential hemorrhages on stage from the hand of another singer. Inadvertent so far as I can tell. If you're young and you're hit in the neck like that, the cartilages are pliable and they tend to collapse and snap back into position. If you're an old person, such as I, they are bone and they fracture. Are there any physicians, laryngologists? in the room today? Ah, good. That's also useful to know for surgical reasons. For example, if you do transgender surgery where you're trying to do a cricothyroid subluxation on a young person, the larynges are pliable enough to be able to do that. On an older person, they are not, and you need to pick a different operation most of the time. This is front or anterior, back or posterior. Here's the thyroid cartilage. This was from a male. You can see the protrusion, the Adam's apple. If we split it down the middle, here's the thyroid cartilage. Remember, it's C-shaped, so there's no back part. Here's the cricoid cartilage, the arytenoid atop the cricoid, and this white structure, mislabeled vocal cord. First of all, we stopped using the term cord about 30 years ago in favor of vocal fold, more accurate description. The German term vocal lips is more accurate still. However, this white thing is neither the vocal cord nor the vocal fold. It's mislabeled altogether. Please remember it as a reference point. We will come back to it. The laryngeal skeleton is connected by cartilages, and these cartilages are synovial. They're made up of the same materials as your elbows and knees. Furthermore, they are not screw-like joints. They have pliability. They move in multiple directions. They also are subject to the same maladies as other joints: dislocation, subluxation, infection, arthritis from aging. There's a pleasant thought. So these joints behave just like everything else. The cricoarytenoid joint, we'll talk about more. It's very well known. For the physicians in the room, I will mention the cricothyroid joint. When I wrote a paper on this in the 80s, there was only one article from 1963 in the German literature talking about clinical issues with the cricothyroid joint. However, they are common and missed routinely. This is the area that gets injured when athletes get elbows to their larynges, external trauma. If this joint fails to move freely so the cricoid and thyroid can approximate each other, it's usually misdiagnosed as a superior laryngeal nerve paralysis. You can have inability to get cricothyroid approximation and raise pitch due to dysfunction in this joint because it's just below the surface. It's a much more common injury than people recognize. Here's the larynx again: thyroid, cricoid, hyoid bone, epiglottis peaking above. Now, anatomists are notoriously unimaginative. So, as I said, if you know those three cartilages, you know everything else. This membrane between the cricoid and the thyroid is cleverly called the cricothyroid membrane. This is the thyrohyoid membrane. Now, picture in your mind's eye, with your three-dimensional X-ray vision, where the vocal folds are and where the arytenoid cartilages are. Whether you're in an office or in a studio, you should be able to look through the person with whom you are working and know where the structures exist. So as we start to take things away, here's the thyrohyoid membrane gone. You can see the leaf-shaped epiglottis attached to the inside of the thyroid cartilage. Here the cricothyroid membrane is gone and this space is artificially widened, but you can see the signet ring-shaped cricoid cartilage perched atop it, the pyramidal-shaped arytenoid cartilages with their bodies, and the muscular process to which a part of the vocal fold attaches. Note that the arytenoid cartilages are sitting on top of a curved skeletal structure. Their joints are elliptoid and vary in height. Very complex motion. So here's anterior or front, posterior, right, left, hyoid bone, thyroid cartilage, epiglottis, the arytenoids, and extending from the vocal process of the arytenoids to the inside of the thyroid cartilage, that white structure, which was mislabeled vocal cord. For the physicians in the room, there is an embryologic fusion plane between the vocal process and the rest of the arytenoid. It is a fracture line waiting to happen. Vocal process avulsion is a troublesome injury. It creates disproportionate dysphonia. That fragile structure is why we never put an instrument below the vocal process and lift. When we're reducing dislocated arytenoids, the technique is different and stays away from that joint. The arytenoid used to be described as rocking, gliding. It's now basically considered rotation, but it's an important joint to appreciate and understand. Here's the arytenoid cartilage. Here's the top of the cricoid cartilage. These are CT scans from Jean Abibal and Abel Castro from a couple decades ago in Paris. When we are phonating, the arytenoids are together sitting on top of the cricoid arch. When we take a breath, this is the same person inspiring. The arytenoid cartilages not only come apart, but they change angulation completely and slide down that curved cricoid surface. This motion is so complex that we are not able to recreate it. So once it's injured, it's injured. We can compensate somewhat, but never truly restore. Let's see. All right, so this is another one of Abibal and Castro's, surgery I can do, computers or something else. CT scans, and this is a normal human. This is the arytenoid, this is the cricoid. Look at the small area of contact between the arytenoid and the cricoid. Here it is again. This is a normal human specimen. Considering how small and fragile that area is, it is amazing that we have so few arytenoid dislocations with all the anesthetic intubations that happen. Not surprising that they occur. Surprising that they don't occur all the time. The intrinsic muscles are responsible for adduction, that means adding together, abduction, abduction, which means pulling apart, and longitudinal tension, among other things. Once again, for your multiple choice quiz, you only have to remember one nerve and one muscle, maybe another one. The superior laryngeal nerve innervates the cricothyroid muscle, which stretches your vocal fold and lets you elevate pitch, among other things. Pretty much everything else is innervated by the recurrent laryngeal nerve. None of that is strictly true, by the way, but it's close enough. It's the traditional teaching. There's some cross-innervation, but for practical purposes, you can remember that. Furthermore, the posterior cricoarytenoid, that's the second muscle you get to remember, lets you breathe. It's the primary abductor. It pulls the vocal folds apart when you sniff so that you can take a full breath of air. Everything else is designed to bring your vocal folds together to protect your airway and, incidentally, to let you speak and sing. So, cricothyroid, longitudinal tension, posterior cricoarytenoid, breathing, everything else, adduction for all intents and purposes. The thyroarytenoid, the lateral cricoarytenoid, and the interarytenoid are the primary adductors. Now, when I was a resident in the late 70s, we learned the names of all these muscles for one very important reason and one very important reason only: to pass boards. Afterwards, we forgot them because they had no clinical importance. Times have changed. Every day we diagnose weaknesses in the vocal folds using sophisticated techniques, confirm them with laryngeal electromyography, and our voice team uses them to guide therapy. So if we have a slight sluggish vocal fold that's due to a 30% reduced recruitment in the right superior laryngeal nerve, our voice team eliminates all the compensation, provides exercises to strengthen the cricothyroid muscle, and bring the system back up into balance. It's the same thing you would do in a gym if you had a weak biceps muscle. You wouldn't curl 100 pounds of free weights. You get on the biceps machine, which might let you do 10 pounds, and isolate and strengthen the biceps. Modern voice therapy and singing voice therapy is muscle specific, based on a good diagnosis, and does the same thing. Cleverly enough, the posterior cricoarytenoid originates from the posterior aspect of the cricoid cartilage. It starts into the muscular process. When muscles are activated, they shorten. When it shortens, it pulls the muscular process of the arytenoid out and up. And this is an important concept. This dotted line is the neutral edge of the vocal fold. Here's the posterior cricoarytenoid muscle that we just discussed. So when that muscle fires, it doesn't just open the vocal folds, it also changes the shape of the vibratory margin. So does the cricothyroid muscle. Remember that stretches, it does longitudinal tension. What would you expect it to do? Sharpen and thin the edge like a stretching rubber band. How about the vocalis muscle? I will tell you that it runs next to that white line, this labeled vocal cord. When you fire that muscle between the arytenoid and the thyroid cartilage, what moves? Nothing. It's isometric. So it bulks up, forms the body of the vocal fold, and provides lateral resistance. So if you have a weak vocal fold, paretic, maybe from a virus, maybe from Botox, when the other side hits it, especially when you're phonating loudly, instead of providing good resistance, it gets knocked out of the way and the voice breaks up and flutters. That's why when we treat people with botulinum toxin for spasmodic dysphonia, they recover fluency, but not normalcy. If they're singers, when they try to sing loudly, they are likely to be symptomatic unless you use microscopic doses. And that's because of the interference with the resistance function of the vocalis or medial belly of the thyroid muscle. So when we are talking about muscle function and muscle weakness, we're not just talking about gross motion. We're talking about very specific effects on the shape and function of the edge of the vocal folds. The thyroarytenoid muscle goes from the arytenoid to the inside of the thyroid cartilage. That white structure called focal cord would be here. The medial belly of it also is called the vocalis muscle. The lateral cricoarytenoid is quite important clinically. It brings the vocal folds to the midline. So if we're doing laryngeal electromyography, that's sticking a little needle in and listening to the electrical activity. When we're in the vocalis muscle, we hear shh when we have somebody say prolonged firing. If we're in the cricothyroid muscle, we hear shh. It fires briskly to bring the vocal fold to the midline and it doesn't have to do much. So if we want to inject Botox, that signal will tell us where we are. Again, for the physicians, those of us who care for a lot of voice patients, see people with recurrent granulomas, inflammatory masses that keep coming back after operations and good reflux treatment. One of the reasons is a lateral cricoarytenoid dominant pattern. It's supposed to work with the inner arytenoid muscles, so this area of the vocal fold contacts over a broad surface. When the lateral cricoarytenoid is dominant, there's forceful point contact here, and then the rest of the vocal fold comes together, and that creates trauma. And the cure for that is to put some Botox in the lateral cricoarytenoid muscle, and while it's working, get voice therapy. And more often than not, the granulomas go away without surgery and don't come back. So again, this anatomy is not esoteric. It's basic, everyday, how do I take care of my patients and students? The inner arytenoid is the only truly bilaterally innervated of the intrinsic muscles, and it provides medial compression. It closes the posterior glottic chink. An open posterior glottic chink is a normal variant. We don't necessarily want to close it, but there are ways to teach people to do that if there is a reason to. The cricothyroid muscle brings the cricoid and thyroid closer together. As it does, the arytenoid rocks back, and consequently, the vocal fold length increases. And that is our pitch-raising mechanism. We'll talk more about how that does that in a moment. Now, I told you that all of those intrinsic muscles were connected to parts of the laryngeal skeleton. And the laryngeal skeleton was connected by joints that have pliability. So as you squish the larynx together or according it apart, the condition of those joints and the relative relationships of the cartilages vary, so too do the resting lengths of the intrinsic muscles. That is one of the reasons that in classically trained singers, where we value uniformity of quality throughout a range, singers are trained to keep the larynx at a relatively constant level regardless of pitch changes. That also maintains a constant length of the vocal tract for resonance purposes. But it also allows fine adjustments of intrinsic muscles without gross changes that you get from the length differences that occur if you let your larynx pop up when you go to a high note. The anatomy of the inside of the larynx can be divided into the true vocal folds, above them the false vocal folds, and a little envelope in between called the ventricle of Morgagni. Here's the trachea. Here are the true vocal folds, false vocal folds, and the ventricles. This is the vocalis, or medial belly of the thyroarytenoid muscle again. Note first that the contact edge of the vocal fold is not two-dimensional. It has millimeters of distance. It's not like two pieces of paper as we sometimes misinterpret from pictures. It's more like two fingers touching. The length of that contact area varies. There's more of it there in a bass than there is in a soprano. But it is important for reasons we will see more about in a moment. Note too that this is convergent. It's steeple-shaped. And that convergence is extremely important to the function, particularly the aerodynamics of the system. If we do something surgical, like have a thyroplasty implant too low, that squares off this convergence excessively, when we look with a stroboscope, it will look like we have a great result and the vocal folds are together, but the patients will complain of strain, increased effort, because of that variation in the aerodynamics of the system. That comes into play when we reconstruct vocal folds for scar, when we do framework surgery, and in other scenarios. The vocal folds can be divided into musculomembranous and cartilaginous portions. At birth, they're about 50-50. In adulthood, it's roughly 3/5 musculomembranous and 2/5 cartilaginous. This is a picture of a normal human, anterior, posterior, arytenoids, epiglottis, true vocal folds, false vocal folds. Now, unfortunately, we physicians are trained that the musculomembranous portion of the vocal folds is phonatory, where we make sounds, and the cartilaginous portion is respiratory. There is too much we don't know to behave that way, especially in the operating room. For example, all of us who are experienced clinicians have seen patients who have webs, that is scar, that attaches the two musculomembranous vocal folds so that they are not functional. And yet the people have pretty good, clear voices. When we look at them with stroboscopy, the cartilaginous portion mucosa is functioning as a very effective oscillator in making a usable mucosal wave. That makes me wonder whether that part of the vocal fold might have some function in high-performance voice use. The research to really confirm that is still lacking so far as I know. But the lesson is, until we know more about the function of the mucosa over the cartilaginous portion, it seems prudent to treat it with the same respect that we show to the musculomembranous portion. The tradition in surgery is that if you have a lesion back here like a granuloma, you can just go in with a laser and cook it, because it doesn't matter to voice. I can't prove it with evidence, but my suspicion is that's not true. And I am sure that we don't know enough to assume that it's true. So we advocate delicate surgery anywhere in the larynx. The mucosa forms the smooth, lubricated contact surface that allows our vocal folds to come together and pull apart effortlessly. The lubrication comes from a combination of serous and mucinous glands. The serous glands secrete thin, watery type lubricant, and the mucinous glands thick lubricant. We mix them. Many of the things that you think of as drying don't actually dehydrate the lubricant. They shift, like antihistamines, from a serous to a mucinous predominance. It's like thickening the oil in your car. It doesn't work effectively. It makes it more difficult for the vocal folds to pull apart once they have come together. And many of the things that we use to treat, of course, you have to be hydrated, but even hydration and mucolytics help shift to create the correct, thinner viscosity. So don't just think of lubricant as dry and wet. It's more complex than that. Most of the airway is covered with pseudostratified ciliated columnar epithelium. It's got little hairs on it. The little hairs would last long with the vocal folds smashing together several hundred times a second. So the vocal folds have different kind of mucosa that doesn't appear anywhere else in the airway. When I was in training, we didn't know that the mucosa over the vocal folds was any different from the mucosa on the inside of the cheek. But it turns out that it is. In 1975, Minoru Hirano in Japan described the layered structure of the vocal fold, which consists of an epithelium, superficial, intermediate, and deep layers of lamina propria, and muscle. You already know some of these friends. That muscle is the vocalis muscle that provides lateral resistance. The intermediate and deep layers of lamina propria together are called the vocal ligament, and that's that white structure that was mislabeled vocal cord around which this anatomy is built. And the epithelium and superficial layer of lamina propria, also known as Reinke's space, form the mucosal wave that courses from inferior to superior and is what you think of as vibration or oscillation of the edge of your vocal fold. So where are we so far? We understand vocal fold anatomy in layers and physiology, function in layers, mucosal wave, body for lateral resistance, a transition layer. We also came to understand that wound healing occurs in layers. There are few fibroblasts in most people superficially. The vocal ligament and muscle are rich in fibroblasts. And of course, in this layer, there are also proteoglycans and other components of wound healing. Then we came to understand that most benign vocal fold pathology in singers and other professional voice users, nodules, cysts, polyps, is also superficial. Epithelium or superficial portion of the superficial layer. So we developed surgical instruments that permit precise surgery so that we can remove pathology superficially without traumatizing subjacent layers, provoking fibroblast proliferation and creating scar that obliterates all of this elegant structure that we cannot restore. That, in a nutshell, is modern laryngology. Everything else is ways to achieve those goals. So, how many of you lie awake at night wondering how the epithelium is attached to the superficial layer of lamina propria? Well, there is a basement membrane. The basement membrane attaches the epithelium to the superficial layer, and it does so through type 7 collagen loops that come from and reattach into the basement membrane, through which pass type 3 collagen fibers, and they create linkages that stop your epithelium from flying off, unless you have a disease like dermolysis bullosa et dystrophica, a basement membrane disease, in which case the epithelium can fly off. The number and nature of these linkages and the wound healing components in this region of the vocal fold vary from person to person and are controlled genetically. How many speech-language pathologists in the room? Okay. So think about this. You get a patient who has vocal nodules, a child. The kid comes into the room. The kid screams, the mother screams, the aunt screams. You say, no wonder they have vocal nodules. Everybody screams. We have 500,000 Italians in Philadelphia, my favorite patients. Most of them live in South Philadelphia. Most of them don't bother with air conditioning. So you can stand in the middle of the street in the summer at dinner time and hear the conversations for 6 blocks in any direction. How come only one kid gets vocal nodules? It's not just behavioral. There's an underlying genetically controlled wound healing issue that's involved that we don't completely understand, but that we need to be thinking about when we're treating and diagnosing these kinds of disorders. The vocal folds are the oscillator of the vocal tract. They make a noise. In order to make a noise, you need to do something that creates energy, power, to set them in motion, and that something is a stream of air that's generated through the muscles of your thorax and abdomen and back. It comes up below the vocal folds. It's called subglottic pressure. This is the one time I like to think that there was an anatomist with a sense of humor. When the vocal folds are open, the space between them is the glottis. When the vocal folds are closed, there is no such thing as the glottis, and everything in this system is referred to as glottic, supraglottic, or subglottic. I like to imagine that someplace, some anatomist got a chuckle out of having the reference for this entire system be a non-existent structure. However, once the power source sets the oscillator into motion, it creates a sound that passes up through our resonator system and makes us who we are. So let's look a little bit at how all of this works. Everything works together in tandem, and it starts with the brain. Even in tenors, it starts with the brain. Ah, you're still awake out there. How comforting. We could spend this entire symposium talking about neurolaryngology, what we've learned, and the enormously greater amount that we don't know. But think about this. When you want to sing something or even say something, you draw an auditory memory, you preset everything we've talked about, from your resonant system to your vocal folds to your power source. You make an utterance. Within milliseconds, you listen to it and fine-tune it, and if you're deprived of auditory feedback and you're a trained singer, you can do the same thing by tactile feedback and go directly to target. It's an enormously complex neurological conglomeration of systems. Small wonder that it doesn't break down more often than it does, and also one of the reasons that we are so adamant about finding a diagnosis based on positive evidence, especially on voice professionals who come in with a voice complaint. If you have a professional singer who has a very early neurological problem, he or she will notice a voice change, maybe before anything else. So it's no longer, well, your vocal folds look fine, must be the way you sing, goodbye. It's a comprehensive, conscientious search in every single patient, because when a voice professional says there's a problem, there's usually is a problem. And if we miss it, it's because of lack of expertise on our part, rarely an imaginary complaint on the part of the singer or other voice professional. And it's common for us to make very early neurological diagnoses on the basis of a voice complaint. That does not mean that all of the singers in the room need to make an appointment with a neurologist next week. That's called medical student syndrome. You're all fine. Respiration, breathing, is of known and obvious importance to singers. It's appreciated reasonably well by speech-language pathologists. It's not traditionally understood and appreciated as much by laryngologists, although otolaryngologists, laryngologists, yes, we're getting there. Breathing is a combination of active and passive forces. Those of you who are still awake out there are using active forces to take a breath, and then you relax. And your elasticity and natural recoil let out the air that you just take, but not all of it. I, however, am up here pontificating, so I am using active expiration, and that's what we use to support projected voice. Singers have a lamentable tendency to refer to their support as the diaphragm. The diaphragm is actually an inspiratory muscle primarily. It's a curved muscle underneath the rib cage. When you fire it, it flattens, it creates a vacuum, it sucks air into the lungs. The external intercostal muscles between the ribs do something similar, and that's not all true either. It turns out that although we have taught for years that the diaphragm is an inspiratory muscle, some elegant work in Stockholm years ago, von Euler, Lee Anderson, Sundberg, showed that the diaphragm is co-activated in elite singers. So it's fired when sopranos, for example, are singing high notes. It may very well be part of the control system for adjusting subglottic pressure. We don't know. But the simple stuff that we teach and the right answers for the test, diaphragm inspiration, our system is much more elegant and complicated than that. And if some of you who are not researchers find this curious and fascinating and go out and start doing research, then this symposium has been a success from the perspective of all of us on the faculty. We have far more questions unanswered than answered. The muscles of expiration are abdominal and back muscles and the internal intercostals. Essentially, they squeeze the air out of your thorax. I sometimes talk about support at this point, but I won't unless it comes up as a question later. So let's look at the vocal folds, and arbitrarily we'll start with the vocal folds together. You hold them together with a voluntary amount of adductory force. When you create sufficient subglottal pressure to overcome that adductory force, the vocal folds move apart, starting from the bottom up and the back forward. You then have airflow through it because of the elasticity of the tissues and the Bernoulli effect of the airflow. That's the same effect that sucks your car toward a speeding truck as it goes past. Between those two effects, your vocal folds start to close, again from the bottom up. Notice we are talking about differential motion of the vibratory margin of the vocal folds. It's called vertical phase difference. And it is important to efficient normal phonation. So, for example, when we have scar and we restore surgically the vibratory margin, we do it over a considerable vertical distance, not just the easy part that we get to on top. Now, for the longest time, we believed, and still largely behave as if, this is entirely an aerodynamic phenomenon. And then Ira Sanders in New York did some very interesting research, and it turns out that the innervation along the bottom part of the vibratory margin is a little different from the innervation along the top part of the vibratory margin, and we still don't understand why. Another nice research project for some of you. Based on Johan Sundberg's work, which you will hear straight from the genius's mouth later, we know that the glottic source, the noise made at the vocal folds, is initially sort of boring. It drops off at about 12 dB per octave. If you decapitate somebody, we try to do that only with plaintiffs, attorneys, and selected administrators. If you decapitate somebody and listen to the vocal folds, it will sound a lot like a trumpet mouthpiece without the trumpet attached. That sort of sound. When you take that glottic source signal and pass it through our system of infinitely variable interconnected resonators, instead of having this boring acoustical profile, when it comes out of your mouth, it's got this nice Pocono mountain range. Each of these peaks is called a formant, and those formants are responsible for a number of things, including your personal vocal identity. That's how when somebody picks up the phone and hears your voice, they know it's you. It's not your vocal folds so much. It's the resonance system that gives you a lot of your identity. As Dr. Sundberg taught us, it also is responsible for audibility. There's a singer's format, there's also a speaker's format. That's what we in the music world call ring. Pavarotti did not have a particularly loud voice, but you could hear him over a 100-voice choir, and you could hear him out in the hall with the doors closed. And that was because of this singer's format phenomenon. Interestingly, it's somewhere where you wouldn't expect it to make a difference. It's around 3,000 hertz. It's about 3.5 octaves above middle C, about 2.5 octaves above the highest note Pavarotti could sing. Why should it matter? But if you notch filter it out, his voice disappears into the background. Furthermore, the center frequency of the singer's format changes depending on Fach, voice classification. I learned this from a wonderful simulator demonstration that Johan did years ago, in which he held everything constant and the only thing he changed was the center frequency of the singer's format. Again, 2.5 octaves above tenor high C. And you could hear the voice go from soprano to bass just by moving the center frequency of the singer's format. So let's talk about how we control things. We'll start with fundamental frequency, which corresponds with pitch. Not the same thing. One's a physical phenomenon, one's a psychoacoustic phenomenon, but they go together. So how do we control pitch? Well, you all know that. You fire your superior laryngeal nerve, you fire your cricothyroid, your cricoid and thyroid come closer together, your vocal fold stretches, so what? Well, you have a larger area over which the subglottic pressure can act, so it's more efficient at pushing the vocal folds apart. The vocal folds are stretched a bit, and you have a fair bit of Bernoulli effect as the air goes through, so they close more quickly, they open more quickly. It happens more times per second. That is increased frequency, that is increased pitch. That's our primary mechanism. Is it our only mechanism? No. And you know that. If you turn on a faucet and then speed it up, what do you hear? As you speed up the water, the pitch goes up, doesn't it? So you can increase flow and have the pitch go up. It's not very efficient, and it interferes a bit with how we control amplitude and loudness, but it works. Does it matter clinically? I think so, but I can't prove it. When we do a cricothyroid approximation, that is when we sew the cricoid and thyroid together so that they can't move, so you have zero cricothyroid change, you would think that you end up with a monotone. All of those patients have between 1/5 and an octave. So they are using a different strategy for pitch control, and I suspect it's this one, but it hasn't really been researched. So, suppose you hear a wonderful lecture, and at the end of the lecture, you want to applaud wildly. Do you do this? No. You spread your hands apart and clap them together. So if you want to phonate more loudly, you increase your adductory force. You increase your subglottic pressure. So when you blow the vocal folds apart, you blow them far apart, increase the amplitude of displacement from the midline. So elasticity stays the same, but the effect of elastic forces are greater, just like a stretched rubber band. Ron, you can tell me later if I got that wrong. And you have a huge Bernoulli effect. So the vocal folds snap together and abruptly cut off the airstream. And that's the mechanism that we use to control vocal intensity, which corresponds with loudness. So, who cares? All of the things we just discussed, we measure daily in our office as we see new patients and as we follow patients who have undergone treatment, non-surgical or surgical. One interesting phenomenon or technique is called flow glottography, which in essence measures the relationship between subglottal pressure and adductory forces. So you have two extremes that you know of. Breathy phonation, clearly an inefficient way to phonate. Pressed phonation, the sound of a baritone announcing to the world that he is indeed a baritone. Pressed phonation is also associated with muscle tension dysphonia, which keeps our speech-language pathologists fed by creating nodules and voice fatigue and other problems. Flow phonation, which is the appropriate balance between subglottic pressure and adductory force, and which is what I hope I have been using this afternoon, is extremely important. Our patients end up being our patients because they have difficulty being heard. It boils down to that. I mean, there are exceptions to people who have trauma and cough and hemorrhage, but for the most part, our muscle tension dysphonia patients and our singers and others get into trouble trying to be heard. One way to be heard better is to use your singer's formant or your speaker's formant. Another way to be heard better is to not work against yourself at the glottic source. Again, this is Dr. Sundberg's work, but he showed that as you go from pressed phonation to flow phonation, the sound pressure at the glottal source can increase as much as 15 decibels. How much is that? Is that a lot or a little? Decibels are a logarithmic measure. So if you go into a factory that has a paper machine putting out 90 decibels, and you turn on a second one, what do you have? It's not 180, it's 93. And it just got noticeably louder. So you turn on two more. You're now looking for ear protectors. You're up to 96. How many machines do you have to turn on to get a 15 decibel increase? 32. So when singing teachers tell you singers to relax your tongue base and sing in the mask, they are doing you a major favor, increasing your audibility and decreasing your effort, and at the same time decreasing your injury potential. Much of what we do in the speech-language pathology office is directed in the same way for the same reason. So we can measure all of these things and do. How important is that? Well, when I first started in this field, laryngology really wasn't much in the way of a field. You had laryngeal cancer, you had vocal nodules, you had vocal fold stripping, that was it. There were a lot of reasons for that. One of them is vocabulary. Until Jim Gould started the Voice Foundation Symposium, there was really no international place for people to figure out what they were saying. You know, when singers walked into a doctor's office and said, I have a little thinning in my upper mid-range, they looked at them with a mirror, figured they didn't have cancer, and sent them on their way. Vocabulary was one thing. The other thing was outcomes. In the hearing world, you do a hearing test, you do an operation, you do another hearing test, you have a measure of whether it worked. In the voice world, there was nothing. If you look at our best journals through the mid-80s, even the laryngoscope, you will find articles on voice where the total outcomes were, and the voices were better. The creation of voice labs, which have many shortcomings, but are a lot better than nothing, allowed us to measure voice functions and voice airway functions objectively and compare findings before, during, and after treatment. They gave us a way to assess outcomes other than relying on our measures or a tape recording, and they allowed the field to develop into a legitimate subspecialty. That was spectrography. It can measure a singer's or speaker's formant. This multi-dimensional voice profile technique measures a number of acoustical phenomena. Strobovideolaryngoscopy allows us to look at vibration. The vocal folds in a normal male speaking voice are roughly 100 hertz, females about double that. Our eye can see 5 hertz. The retina holds an image for 0.2 of a second. So if we don't slow down what we're looking at, we're guessing. Strobovideolaryngoscopy creates an illusion of slow motion that works in fairly normal voices. High-speed video provides true slow motion, so does video chymography, and so do some other techniques. But we need to be able to look at the edge of the vocal fold to figure out what's going on, and especially after surgery, to figure out what we did. We already mentioned electromyography. It sounds scary. I've had it done numbers of times, and I do it lots. We're somewhere over 9,000 laryngeal EMGs. We haven't had a major complication yet. It tells us whether there is full strength or weakness in each of the important individual muscles, and often tells us other things, like myasthenia gravis, which creates weakness and fatigue that we can cure with a pill overnight. Essentially, understanding this anatomy and physiology and the systems and how they all work has made a major difference in our paradigm as physicians, even as scientists, certainly as speech-language pathologists, SVSs and active voice specialists, and as singing teachers. It has not replaced the art of medicine or the art of teaching. It has supplemented it. In addition to listening and understanding, we have objective measures that allow us to do a systems analysis to figure out what's working and what's not working, sometimes to figure out what malfunctioned first. Because if any part of the system goes out, the rest of the system will go out trying to compensate. And to bring to bear what we could not before. We no longer have to shoot from the hip. We can do an intelligent, incisive systems analysis, diagnose the primary and secondary problems, and restore the system to balance in a rational, planned, and organized fashion. And that, these outgrowths of anatomic, physiologic, and voice science are the reasons why you can get care today that you could not have gotten even a couple of decades ago. So, I am a few minutes early, but ready to turn the program over to the experts to whom I enjoy listening so much. Ron, who's next?
Chuck.
Chuck? Chuck Larson.
And early on, when I started doing this, I got some disappointment because people expected me to talk about the diaphragm. So but yeah, the diaphragm is important, but we want to talk a little bit about some other things as well, namely the brain and the nervous system. So, I've got the right button here. Okay, so briefly, I'm going to give you a brief introduction to the brain. We'll talk about general organization of the brain for voice control, specific locations of the brain involved in voice control, and studies of the function of these different areas of the brain and how they relate to voice control. So let's begin with the diaphragm, okay? All right, well, you know, this is important, as Bob just told us, that it's important for inhaling. But what we also know from Bob and others is that it's important for respiration, for speech, and singing. And it is innervated by a nerve, namely the phrenic nerve. And in this diagram, you can see the way the phrenic nerve comes down from upper part of the neck, and it innervates the diaphragm, and it causes us to contract on inhalation. Now, going to the brain itself, gosh, there are like 100 billion neurons in the brain. How in the world can we ever make sense of that? And each one of these neurons has very complex interactions with other neurons. And so it's bewildering to try to understand that. But what we can do is we can take it piecemeal. We can talk about sensory receptors with one type of neuron. We can talk about muscles and glands, etc. We can break down this enormous task into subspecialties. Now here's a diagram of two neurons, one neuron innervating the other through a fiber that's called an axon. And if we look at a different type of picture here, you get some sort of an idea of what it would be like to look inside the brain, where we have all these neurons, all these processes talking with each other. And our job is to try to understand that. So let's take it apart. first of all, we have a peripheral nervous system, and we have a central nervous system. Already it's getting easier, right? So the peripheral nervous system, we can break that down into sensory nerves and motor nerves. And here's a diagram of a person, arm extended, and here's the ear. Now, in both cases, there are sensory nerves connected to these structures, and of course the ear is vitally important for speech and singing, but still they involve these nerves that are going from the periphery into the brain, and we call those afferent. And then from the ear, the signals further go on into auditory cortex, where we appreciate these sounds as something significant to us. Now, we also have motor neurons or nerves. And these go out from the brain to the spinal cord and the brainstem to control fibers, such as the one Bob has just been talking about. And here, for example, we see a caricature of a person whose finger touched a flame that excited sensory neurons in the finger. Signals go into the spinal cord. They make a synapse or a connection with other neurons and send fibers out to a muscle to cause it to contract. This is a simple type of a reflex. So already we've talked a little bit about sensory and motor neurons. Now the same thing applies to the diaphragm. There are motor neurons going to the diaphragm. So what we want to do then is figure out, where do these motor neurons come from? We also have motor neurons going to the larynx to control of all of our laryngeal muscles. We want to know where those neurons are coming from and what they're doing. And we've just heard a very great talk on the function of the laryngeal muscles in voice control, and I won't go into any of that. So what we're going to do is talk about neurons in the brain, how the neurons work together to produce and control voice. So how do we do this? Well, first of all, let's step back and get a bird's eye view of the whole thing. Here we're looking at a drawing of the human brain. In the front part, the frontal lobe, that part is concerned with personality, putting things together, cognitive abilities, etc. Then we've got the auditory cortex in the temporal lobe, that's largely hearing, some speech and language processes. In the back, we've got the visual cortex, that's where visual information is arriving in the brain for processing. And then in the parietal lobe, we have integration of sensory modalities of different types. For example, integration of hearing with touch or vision with touch to form the world around us. So these are just sort of the general processes of the nervous system and where they take place. Now, we can also look at the brain from the inside. So in the upper quadrant, you see a picture of the brain from the outside, but in the lower part, we see a picture of the brain dissected in the midline. And we can see that in part of it, we still have these part of the cortical surface folded around inside, but then what we also have, and I'm not sure if this works or not. No, it just advances it. Okay. Well, at any rate, I won't do that again. At any rate, we have this thing called the corpus callosum, where the two hemispheres come together. Now below that, we have the brainstem, and that's what you're looking at here. Now the brainstem sits atop the spinal cord, and it's really interesting. As you can see, it's divided into three different sections: the medulla, the pons, and the midbrain. So let's take them apart and look at each part individually. So the medulla, this is really interesting. This is where basic life support processes occur. Now what you have to do is you have to think about this in the terms of evolution, from the most simple types of animals to us, okay? And so the simplest types of animals just had to control things like breathing, swallowing, eating, using their tongue, etc. And so that's where we have these processes controlled at the lower part of the brain, some in the medulla. And we have both sensory processes going on there and motor processes. So motor neurons in the medulla, they send their fibers out to structures such as the larynx and the tongue. And of course, the larynx is vitally important for these things we've been talking about already today. And they are controlled by a structure called the nucleus ambiguus. What a name for a anatomical structure. Bob had a lot of fun with some of the anatomist terminology. It gets its name from the fact that the early anatomists couldn't quite figure out which structure it really controlled. They thought it was ambiguous. It's the 9th, 10th, and 11th cranial nerves. Okay? That's where the term comes from. But this is the nucleus in the brainstem that controls our laryngeal muscles, and also some other pharyngeal muscles, palatine muscles, etc. Okay, let's go to the pons, next stage up. Here things get a little bit more advanced. The animals are more advanced, they have more capabilities, and here we see some other structures innervated. For example, hearing and balance, where we get input from hearing mechanisms, balance, and then also facial appearance, controlling our lip muscles, jaw control, eating, eye movement. So these are all of a higher order than just the basis of keeping us alive. These control higher order processes. And so we see in the pons the auditory nucleus, facial nucleus, etc., for controlling these other structures that are quite important for speech and language, as we all know. But just from the evolutionary perspective, we start low and working up the ladder here. Then we get to the midbrain, and here things get even more interesting. Here we have a part of the brain that's involved in orientation to our environment. For example, if we see something, a stimulus attracts attention to our visual field, we orient our eyes to it, we look at it. We hear a sound, we respond to it. So we're responding to these complex stimuli. And there are many different types of stimuli. Some of them are innocuous, but others are frightening, and they may cause us to flee, fight, or to scream. And that brings us to another important property of the midbrain, and that is, this is a part of the brain that's responsible for innate types of vocalization. And here I'm talking about emotional types of vocalization. Screaming, crying, etc. Because, again, thinking in terms of evolution of animals, as animals became more complex, they started using vocalization in a way that helped them to survive. We're going to come back to this in a very interesting way to talk about speech in a few minutes. Now, this structure that I was just talking about, central gray, or PAG as it's called, surrounds an aqueduct. And if you place an electrode in there and stimulate it in an awake animal, you cause a natural sounding vocalization to occur. Here are 3 different monkey calls produced by stimulation of this area while they were totally anesthetized. And what you get is you get jaw opening, you get lip retraction, you get contraction of the diaphragm, intercostal muscles, laryngeal muscles, and you get all from stimulation of this area. And also, you can see that if you have an electrode in the diaphragm, you get contraction of the diaphragm, which causes inhalation, followed by contraction or relaxation, and the scream that comes out of that. So you may be wondering, why am I talking about this now? I'm here to learn all about speech and language. Bear with me, we'll get there. Okay. And at any rate, Gert Holstig put this diagram together several years ago, which is very interesting. It starts at the top with the limbic system. Now, the limbic system is that part of the brain we normally think of for controlling our emotions. And then that feeds down into the periaqueductal gray, or central gray, which then goes to a couple of other nuclei. And then it winds up at the bottom, going into the abdominal muscles, laryngeal muscles, pharyngeal, perioral, and mouth opening muscles, all producing vocalization. So here we have this system that we as humans inherited, okay, that allows us to vocalize. But usually those vocalizations are done in an emotional manner. Okay, so now let's go to the human cortex. This is a slide from a study done by Chrissy Ledo and Johan Schultz several years ago. What you're looking at are slices of the human brain, and they use a technique called positron emission tomography, which cause active areas of the brain to show a different color. And so what they did in this study is that they had people produce a whole lot of different types of speech sounds. Not even speech sounds, whispering, you name it. And you can see that all these areas that are highlighted there are different parts of the cortex that are involved in these different types of human sounds, speech sounds, etc. And they found they were all connected to the PAG. So what this means is that we as humans, when we are talking, speaking, we are engaging the higher centers of the brain for controlling our speech and language, but we also have connections with this more primitive system which imparts emotion. And I have a hunch that those of you who are singers probably engage this a lot if you are singing emotionally. And I think most people would agree singing is a form of emotion. I don't have any proof of that. I don't think anybody's studied that. But it's a tantalizing idea. Well, let's now go to some other parts of the brain. Here we're looking at a picture of the brain, and we see the auditory cortex, language cortex, gustatory cortex, etc. Connections to the tongue, the ear, eye, etc. So we want to start now looking at some of the other functions of the brain. Now we'll start with the basal ganglia. The basal ganglia, as many of you probably know, is a structure beneath the cortex, and when that's damaged, people have disorders like, Parkinson's disease. So that's a very important thing for us to know about. And it involves a tremendously complex circuitry, which I'm not going to go into, but we have to be aware that when we're dealing with people with a speech disorder like Parkinson's disease, that we're talking about this part of the brain and the abnormal function thereof. So we'll get to the cerebral cortex. And to begin with, we have a sensory cortex and a motor cortex. And both of them are organized such that at the top of our brain up here, that's where our feet are located. And then as we go down the sides, the body comes down to the side here. And down at the bottom, that's where our face is located. So that's general organization. Now, here we have a slightly different scheme of organization where we can see where there's word formation in the front part of the brain. There's planning of complex movements. We have auditory cortex, language comprehension, vision, spatial orientation to stimuli, etc. These are all these higher order functions that are distributed throughout the brain. Now, so which parts of the cerebral cortex are involved in voice control? Well, one of the ways we study that is through fMRI or PET, especially people with brain dysfunction. Or, on the other hand, we will take normal people, healthy people, and we will use the same techniques such as fMRI, PET, imaging, EEG, and look at parts of the brain that are active. So this is a slide from some of Steve Brown's work, and he had subjects do a couple of different vocal tasks, just vocalization. And what he found is there are two little areas in the frontal hemisphere, the motor cortex, that were active just with vocalization alone. He also did a study where he contrasted rest versus harmonization. And this is what you normally do in fMRI. You have one condition that's like a rest, and then you have your task condition. So contrasting them, he isolated several different parts of the brain that are active with harmonization. And then at the bottom, he also contracted harmonization with monotonic vocalization and found different areas that are active. Now here's another study. In this study, what they did is they had people modulate their pitch, vary the pitch of their voice, and you can see there's several different areas that are active. So one of the points to get across here is that there's not a single part of the brain that's doing these things. The brain is really complex and we don't understand most of it. Several parts have to work together to do these things. And I threw this slide together just to illustrate all the areas I know of from other studies that show activation of brain areas with some types of vocalization. And here again, we can see it's a very distributed system. So how do we control our voice? Well, we look at it as a two-stage process. We have an internal model, what we want to say, and we get feedback. And we can look at that from the perspective of a simple model where we have the subject, action is the voice, the event is vocalization, and sensory feedback. Okay? So, what we do is we want to study how people control their voice, and we do this by changing their auditory feedback. And in this diagram, we see the person's voice picked up by a microphone. We take that acoustical signal, run it through a pitch shifter, shift the pitch, like that, and feed it back to them. And when we do that, we see in the top diagram here, where the stimulus up at the very top is an upward pitch shift. The red trace shows a downward slope indicating the person lowered the pitch of the voice when it was shifted up. In the bottom part of the graph, there's a downward pitch shift and the person raised their pitch. Now this happens fast. The stimulus was 200 milliseconds, it's a fifth of a second. So that response occurs within a tenth of a second. So it's very fast and it knows which way to go, because it's correcting for an error. That's what this system does. It helps us to regulate the system. So we did that along with fMRI, and we showed these small areas of the brain that are active with correcting for errors in the voice. Again, these are in motor cortex in the laryngeal area. Now, two of my former students, Nadine Abraham and Roosman, they studied voice control in musicians with absolute pitch and relative pitch. And these traces show these vocal responses to pitch-shifted auditory feedback. The red traces show people with relative pitch, the blue absolute pitch. And both of them show larger responses than non-musicians. And responses ceased quicker. So they have a large response and it gets over with quickly. Using EEG, we then found that there was a distinct difference in the EEG responses of the musicians with absolute pitch compared to the other people. And we also found that the singers with absolute pitch, and some relative pitch also, had more left hemisphere activation than the non-musicians. Usually we think of sounds being in the right hemisphere. Well, showing this in the left hemisphere is very important. Now, Christina Nishimura and Sona Patel, they did a study on volitional responses to feedback. And in this study, the subjects were told, all right, change the pitch as fast as you can when you hear the change in pitch feedback. So the red trace represents the fact that the people were supposed to follow the direction. So if the pitch went up, they're supposed to go up. So go, or if it went down, go, like that. So these are voluntary responses. And what you can see for both the upward and the downward is that the responses that followed the direction occurred earlier than those that opposed it. Now those opposing direction, they are part of this reflexive mechanism I talked about. And in this expanded graph here, you can see that even with those following responses, there still is a small tendency to have that reflexive response. So what this tells us is that following is a very fundamental property of the system. That is vocal mimicry. That's how most animals learn to vocalize. We are born with that. We have some part of that control with us. And this study demonstrated that very nicely. Now, we've also looked at people with Parkinson's disease, ADHD, and children on the autism spectrum. And here's a study from the Parkinson's disease study where we saw that people with Parkinson's disease had larger responses to pitch shift and feedback than healthy controls. And here, young adults with ADHD had larger responses than normal healthy controls. And then for children on the autism spectrum, we've done 2 studies. In both studies, we show that children on the spectrum have larger responses to pitch shifted feedback than healthy controls. And what's really interesting is that Shivani Patel, who did this study, she also did the genetics, and she tested the mothers of these children. And some of the mothers who had this genetic trait also showed these enhanced responses to pitch shifted feedback, which is totally a surprise to us. Okay, so I'm just going to run through the summary quickly. We've got the nervous system with motor neurons, sensory neurons, the ear, etc. We've got the cerebral cortex for volitional control. We've got cerebral cortex for audition, ear, muscles controlling vocalization, etc. We've got this midbrain region then, which is controlling emotional vocalization. Mine is probably more active than yours right now because I'm speaking in front of a bunch of people and it makes me nervous. And I have a hunch that when we are nervous, that's what happens to us. When we're crying, definitely, okay? Or screaming, maybe really angry. That's this PAG rising up to confront us. Okay, and then we can talk about the motor neurons in different parts of the brain, like the medulla, the basic types of muscles. We go up to the pons, things become more elaborate. Then we get the ear for auditory feedback, the larynx, lips, tongue, somatosensory feedback. And that is the end of the show. Okay. I never know. I think I did it in time.
This is me, and I'm going to talk about the breathing system and how it is being used in for phonation purposes. The menu that I'm going to serve is first to touch upon the question why breathing could be relevant. I mean, after all, everybody is able to breathe, so what's so special about breathing and voice? Then I will talk a bit about breathing apparatus, expanding a bit of what Dr. Sataloff talked about, and then some words about lung volume, how much air we could inhale and exhale, subglottal pressure, a key concept to all kinds of phonation, and breathing and voice is fifth thing. So why is breathing so important to voice? Well, you have different types of voice onset, starting, phonation, and that is a question of synchronizing, bringing the vocal folds together by adduction and starting generating subglottal pressure. So I will talk about how to start a tone. One method is to have a heart attack sounding like this, and then you first adduct the vocal folds, and then after a little while you start the subglottal pressure, and then you get a rather slow vocal fold vibration attack. That is the heart attack. The staccato attack is what you probably may visit when you laugh, like that, but you could also laugh in a different way. I'll come to that in a little moment. Okay, staccato attack, then adduction and subglottal pressure are started at the same time. So here we have adduction and there we have subglottal pressure, and you see that they are synchronized, and you get a rather smooth attack of the start of the voice. And then the third type of vocal attack, that is when you laugh at like this, ha 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 ha, then that is the breathy attack, and then the subglottal pressure is early and adduction comes later, and that is then can be illustrated like this, and you get a rather slow onset of the vocal fold vibration and the sound production. So all this is a question of synchronizing the onset of the subglottal pressure, the lung pressure, the air pressure in the lungs, and bringing the vocal folds together. Another point that makes breathing technique, breathing behavior important to voice is the tracheal pull, which is a mechanical link between the breathing and the voice. The lungs are hanging in the larynx, and they weigh some grams or kilos or hectares or whatever, so they try to get the entire system lower down. They are attached to the hyoid, and the hyoid is attached to the skull. The fact is that there is a pulling force directed downward if you are standing in an upright position. That is called the tracheal pull. The tracheal pull is strong when you have lots of air in the lungs, when you have high lung volumes, and that means that the diaphragm is far down in the trunk. And after inhalation, with abdominal wall or flank expansion, and you have lots of tracheal pull. The tracheal pull, here you see the vocal folds, and the trachea, and the tracheal pull wants to pull the entire package down, and it also importantly induces an abduction effect, so it tends to open the glottis. This means that it counteracts pressed phonation, which makes it more relevant to the phonatory system. So breathing strategy can influence the voice, as I will talk about a bit later. And finally, subglottal pressure is heavily influencing the phonation, like Dr. Scherer will talk about in a while. So here you have some examples. The steepness of the pulse, of the flow pulse through the glottis is regulated with the subglottal pressure. So the higher subglottal pressure, the more steep the cutting off of the airflow through the glottis in the vibratory system. The duration of the closed phase is also affected by the subglottal pressure. As you can see here, this is for different types of voices, and at low subglottal pressure you have a lot of increase of the closed phase. At high subglottal pressure you don't get very much of increase at all. Amplitudinal flow pulse is also affected by the subglottal pressure, so the higher the pressure, the more amplitude of the flow pulse. And the amplitudinal fundamental is also quite heavily influenced by the flow pulse and hence by the subglottal pressure. Finally, the spectrum slope, the slope of the spectrum that you produce, is also heavily influenced by the subglottal pressure. So a small, if you increase the subglottal pressure, you get a small increase here in the low frequency range, and a big, about 1.5 times as many decibels in the high frequency range, around 3 kilohertz. Thus, subglottal pressure is very important to voice, and therefore breathing is quite relevant to voice. Now the breathing apparatus, which I will run through at allegretto speed, because you have heard it already. we have two complete muscles for ventilation. One is situated in the rib cage, and the other one is situated at the bottom of the rib cage, and is the diaphragm, which is the antagonist of the abdominal wall. So the intercostal muscles that are external, that lift the ribs and make the volume of the rib cage bigger, and then the internals that by contraction goes to squeeze the rib cage. So if you want to increase the subglottal pressure and phonate more healthy, then you squeeze, you reduce the volume of the rib cage and compress the air, and that gives you a bigger subglottal pressure, and that gives you a louder voice. The bottom of the rib cage is the place for the diaphragm, and it can be pushed up towards the rib cage by the abdominal muscles. So you could contract the abdominal muscles, and that would bring up your diaphragm in the trunk. And the diaphragm, when the diaphragm contracts, it flattens, so it lowers the bottom of the rib cage, and then that widens the volume of the rib cage. So that is an inspiratory muscle. Note that the diaphragm is fastened to the bottom of the rib cage, so it is high here in the front and it is low in the back. And when you contract the diaphragm, the abdominal wall normally expands, and vice versa. Some people actually say, and probably also believe, that they cannot contract willfully the diaphragm, and that is a lie that nobody should believe anymore in this room, if there was anybody who believed it. And I want to invite you to contract your diaphragm by your own will, and that is the exercise is then to make your abdominal wall hard and then pronounce a soft S sound. Everybody is able to do that. What you do then is that you contract the abdominal wall to make it hard, and you co-contract the diaphragm. So, and the co-contraction of the diaphragm prevents the subglottal pressure to go high, and therefore you could pronounce a soft S sound. That is the simple exercise. Okay, so this is a summary of the muscles. You have the intercostals, the internal for the exhalation and the external for the inhalation. Then you have the diaphragm and the abdominal wall to regulate what the bottom of the rib cage is doing. You could, if you have two shoes, you could demonstrate to yourself how to contract, how it feels to contract the diaphragm. But I also brought a little thing that could demonstrate what happens in real time. This is it. It is actually, to tell the truth, I have put on my body two respiratory bands, one for the rib cage and one for the lower part. And if everything is working here, I could start the machine, and you see these four tracks. One is the yellow one, and that is the rib cage, and then the lower one is the blue one, and that is hiding now for some reason, but I could push the button and then it re-enters. Yes. So when I do this, the lower compartment is varying. Now the green one, that is the lung volume. So if I close my glottis and contract the diaphragm, contract the abdominal wall like this, and close the glottis. Then I have the same lung volume, but in order to get the green line to stay, I need to adjust the balance between the amplification of the blue and the yellow curve. And perhaps this is it. Yeah. Yeah. Comes up. And then you could see how much you could inhale and exhale. And you could also try to just breathe with your rib cage. Not bad. And then you could I could try to breathe just with my abdominal wall and the diaphragm and keep the rib cage, the yellow curve, constant. Yeah, so this is a simple tool in order to direct the attention to the breathing behavior. Simple and straightforward. Okay, thank you very much, and stop it. Okay, that was the respiratory tract. Now there's elasticity. The subglottal pressure, the pressure in the lungs, is regulated not only by the muscular activity but also by elasticity. And how does elasticity feel? Well, I invite you to visit that experience and inhale deeply and then close the airways and then relax and then open the airways and then everybody will exhale. So inhale, close glottis, relax, open the glottis. Yeah, that always works. And you could also, so that means that elasticity is actually an exhalatory force at high lung volume. Elasticity is exhalatory when you have lots of air in the lungs. And when you have not so much air in the lungs, then you get the opposite effect of elasticity. So exhale deeply, close the glottis, relax, open the glottis, and everybody will inhale because of the elasticity. Okay. So elasticity is a force that is varying all the time as the lung volume varies. And that is then quite an important aspect of phonation because, as I mentioned before, subglottal pressure is a key concept to the regulation of the vocal folds. Measuring sound pressure, that is so simple, I hesitate to mention it. You just buy a little tubing and fold it to a U shape, the letter U, and then you pour some water into the tube, and then you will have water columns in both ends, both left and right part of the tube. And if you then push a little air, a little pressure into the open end of one, then there will be a difference between the left and the right water column, and that is the pressure measure. It's simple like that. You could buy any tube and try yourself. It is most entertaining. Okay, so you could in terms of centimeters of water column, and you get the centimeters of water column from the YouTube. Okay, so here we have now lung volume, and here the lungs are 100% full, and here they are 0% full. And here you have subglottal pressure that in upright position is produced by the elasticity, by only the elasticity. Okay, so it is high, 20 centimeters of water column at high lung volumes if you are in upright position, and then about minus 20, a sucking force of about 20 centimeters of water column at 0% of your vital capacity of the In the middle, or somewhere just below the middle, you have the REL, the resting expiratory level, and that is a very important lung volume for phonation. How does it feel to be at REL? Well, I invite you to another little exercise, if I may. You make an inhalation and then you burst out in a hopelessness sigh. That brings you to the resting expiratory level. Okay, so and now let's combine this with the fact that you control vocal loudness with the subglottal pressure. And that means that if you are starting a long phrase, you start at a very deep inhalation and have a lot of elasticity force that tends to bring the subglottal pressure high. But you need to reduce that pressure in order to get the target soft phonation. So you need to recruit the inhalatory muscles. Inhalare la voce. That is to be recommended at high lung volumes if you are going to sing softly. And conversely, at a high lung volume, the elasticity may bring you to the subglottal pressure that is needed for lung tone. But then, as you use the air, you will use the lung volume will decrease. So you need to supply more and more exhalatory muscle force as you travel along the phrase. Elasticity forces is also affected by the body posture, and you could experience that as an entertainment before going to bed tonight. So elasticity forces are exhalatory when you have lots of air in your lungs, and inhalatory at small lung volumes, and zero at the resting expiratory level. Lung volumes tends to affect subglottal pressure, particularly in untrained people. So some people speak very loudly after having a deep inhalation. And towards the end of the phrase, when the elasticity force has been reduced to a rather low value, they generally then speak more softly and softly, and you can't hear what they're really talking about at the end of the phrase. So that is something that is not recommended for singing. In singing and in public speaking, you need to be master of your subglottal pressure. Gravitation is another factor that affects the subglottal pressure, because what you have below the diaphragm is weighing kilos, and it wants to travel south if you are standing in upright position. If you are lying on your back, the opposite is true. Then the gravity wants to push the abdominal content into the rib cage, so that is then an exhalatory force. Okay, let me talk a bit about lung volumes. How much air you could inhale, it depends on how tall you are, what gender you belong to, and how old you are. And that is rather uninteresting. So let me skip that and go to the next, which is much more fascinating. This is the lung volume excursions in peaceful breathing, and inhaling all you can, and exhaling. So you have time here and lung volume there. And the maximum inhalation and exhalation then shows you 100% and 0% vital capacity. Okay, the total lung capacity is a bit bigger than the vital capacity, because you can squeeze out everything you have in the lungs as long as you have a rib cage working. Okay, now to the interesting thing. This is normal breathing, peaceful breathing, restful breathing. And it starts here, and this is inhalation, exhalation, inhalation, exhalation. Very small excursions of the lung volume. And the fascinating and charming thing about this is that the inhalation starts at resting expiratory level. The inhalation starts at resting expiratory level. And when do we take a breath? When do we take a breath? When we come to the end of the phrase. And we could improvise an end of the phrase as soon as we want to have some more air in the breathing system. So this is some kind of phrase, and inhalation first, and then the air is being used for phonation, and here's the next inhalation. Then it is interesting to see that people in general take a breath when they reach resting expiratory level. Yeah, and how does it feel to phonate at lung volumes below resting expiratory level? I invite you to another experience. Maybe, if I may, you take a deep breath, you make a hopeless sigh, and without inhalation, you start talking. So inhale, sigh, and then start talking and feel how it feels. That is, yeah. And then compare it with how it feels when you take a breath and start talking at a high lung volume. That feels much more interesting and inspiring. So normally we don't want to use lung volumes below resting expiratory level. So we don't use the full lung capacity that we have. And that means then that reading a new piece of music that you never saw before exposes you to the risk of the phrase being long and you run into very low lung volumes far below red. So this is a graph of the range of lung volumes, of vital capacities, of lung volumes used the first time this singer met a new piece of music. And this is the second rehearsal, third, fourth, and as well to 12th rehearsal. And you see that the tendency is to keep above the red throughout the phrase. And that, I think that may be most convenient breathing strategy, to know how much you should inhale before you start the phrase. Yeah. Classically trained singers have long phrases depending on the work of the composers. They have long phrases, but in normal speech we could do the phrases of any size. When we meet the resting expiratory level, we take a breath. Okay, unscripted speech, small lung volume range is used, and in classically trained singers much. Okay, subglottal pressure. How does subglottal pressure feel? I would like you to experience that by pronouncing an alternately soft and loud S sound. What you do then is to vary your subglottal pressure. So that is nice to know how it feels, okay? Subglottal pressure is the main control for vocal loudness. Here is subglottal pressure, here is the sound pressure level measured at 30 centimeters of distance in front of the mouth. And it is a middle pitch, and it is a subject who is pronouncing a vowel of different loudnesses. And here is the low pitch, and here is a high pitch. And most of the time, there is one single tendency for subglottal pressure and sound pressure level to belong together. And that means that you could ask a question. You could say that this is your relation between subglottal pressure and sound pressure level. And then you could ask, how much sound pressure level do you get for 10 centimeters of watercolor? And the funny thing is that most people get about the same amount. It is about between 70 and 80 decibels at 30 centimeters from the mouth. And you could also ask, how much do I gain by doubling subglottal pressure? And that is a very simple question, and it has an even more simple answer. It is typically you an increase a doubling of subglottal pressure produces 10 decibels of increase of vocal loudness. Okay, subglottal pressure increases with pitch, and you could imagine that the stretched vocal folds need higher pressure in order to vibrate than relaxed short vocal folds. This is subglottal pressure for lyrical soprano singing pianissimos and lyrical soprano singing fortissimo. You have pitch here, and you have subglottal pressure in centimeters of water column there. And then dramatic sopranos, they tend to use a bit higher pressures when they sing as softly as they can and as loudly as they can. I will return to this in a little moment. Yeah, and the dramatic sopranos get a bit more sound pressure level also than the lyrical. Okay, subglottal pressure variation is simple. If you want to sing more loudly, you increase subglottal pressure. So if you have a constant pitch and suddenly increase the sound level and decrease it in this square wave fashion, you do that by doing the increases and decreases of the subglottal pressure. More interesting, well, I showed you this. More interesting is the subglottal pressure in singing, that it is varied with pitch. Yes. So here you see the fundamental frequency of an ascending octave and descending octave with 12. And what does the subglottal pressure do? Well, it moves in a sort of square wave fashion also. High pitch is produced with high subglottal pressure, and it needs to be looped down that. In singing, subglottal pressure must be tailored to pitch. That is what you do. And that is what you need to, that is specific to singing and to wind instrument playing. Wind instrument playing also tend to need to vary their blowing pressure in synchrony with pitch. This can be illustrated in this famous exercise, triad dominant up and tonic up and dominant seventh down. And the pressures used by professional singers for producing this was like this. Twice, and you see the subglottal pressure used for the different tones. So the first member of the new chord is getting the highest pressure in order to achieve a crescendo towards the chord change, which is kind of musical performance. You could also, for just entertainment, look at what happens in staccato coloratura, where you have a lot of work to be done with the subglottal pressure. You see here the fundamental frequency. So every pitch is painted with a rising and a falling gesture of the fundamental frequency. The pressure in the respiratory system is producing a peak, pressure peak for each 16th note, and also in the gastric ventricle you can see. So the coloratura is quite a taxing exercise for the breathing system. Yeah, I could also skip some in the interest of time, just mentioning that breathing strategies are different between different people. Some people sing with contraction of the diaphragm for high pitches and with relaxing the diaphragm for low pitches, and other singers don't do that. They use the diaphragm just in order to reduce the subglottal pressure when they are meeting the low pitch, because the low pitch needs to have the low pressure. Yeah. Let me finish with this and say that breathing and singing breathing and singing in speech differ quite a bit. In singing, you see this very accurately differentiated subglottal pressure that is tailored for the pitch that you are going to sing, while you speak without wanting to say anything in particular, you keep a constant subglottal pressure. That is the final end of this talk. Okay?